Okay, all right. Thank you very much, everyone, and thank you for attending, and thank you for attending the 2023 GRICS Annual Forum. So, for those who don't know me, I'm Mahesh Dola. I'm the GRICS Clinical Director, and it's a pleasure to welcome everyone both here and on Teams for our annual presentation. And before we go further, I'd like to undertake acknowledgement of country. Next slide, please. We like to acknowledge the traditional owners of the land on which we meet and pay our respects to the elders past and present. In this case, we are meeting at LRH, which is the Gunai Kurai and Bunurong people, and we acknowledge the strength, resilience, and survival of Aboriginal people and their connection to their ancestral lands and waters. So after that important announcements, let's move on to our discussions and our presentations. The first thing is to highlight some of the work that GRICS has been doing. I'd like to invite Stuart Harper, the program manager, to go over some of the activities that we have undertaken over the last 12 months. Stuart?
Thanks, Mahesh. So I thought today I'll just share just a brief overview of some of the cancer data over the last 12 months here in Gippsland. So just on this slide, things to note, there's roughly a 14% increase in incidence from 2020 through to 2022. And that's 2,445 cancer cases in the last 12 months, 42% female, 56% male. 58% male. Other things to note on there is the 5-year survival rate. So the 5-year survival rate across all Victoria is roughly 70%. But here in Gippsland, it's only sitting at 65% as a 5-year survival rate. So certainly for GRICS and the cancer sector more broadly here in Gippsland, that is a key figure that we're looking to improve with the work that we're doing over the coming years. In terms of projects that GRICS have done over the past 12 months, so one of our key projects was to deliver a novel exercise and cancer program, and that's been in collaboration with the Latrobe City Council and the Latrobe Community Health Service. We've also provided ADAC facilitation training to over 20 nurses across the region. We provided an enteral nutrition upskilling program for regional dietitians. So that's removed the reliance on stomach therapy for PEG changes. We delivered a breast cancer education evening. Again, we updated all local clinicians in contemporary breast cancer treatment. And another initiative that we undertook was to support Cancer Council Victoria in the rollout of their liaison nurses. So there's a great resource here in Gippsland now providing additional supportive care service to patients. And that's actually seen a threefold increase in referrals to their 13 11 20 number. So it's actually gone from just over 100 referrals last year to over 300 this year. And we continue to engage with our consumer reference group to support all the work that we do. And great to have one of our consumers joining us today. And basically, none of this could occur without the support of a great team. And so I'd just like to finish this slide acknowledging the team here at GRICS and the work that we do to support patients and better cancer care here in Gippsland. Thanks, Mahesh.
Thank you very much, Stuart. Thank you for that high-end summary of the work that's been undertaken. And for today's presentation, we have sort of picked 3 of the work that GRICS have supported and been part of, and also important pieces of work that help to improve care and also get involvement of the local community and clinicians as part of this work. And that is where we develop these clinicians to deliver local projects that improve outcomes for our patients. So the first project is Lung Cancer Multidisciplinary Meeting Enhancing Patient Care, to be presented by Dr. Evangeline Samuel, who's the lung multidisciplinary team chair and one of the main medical oncologists looking after lung cancer patients in the region. She trained in Melbourne at Peter Mac and also at multiple institutions in Victoria. And she's currently undertaking a PhD at Monash University School of Public Health and Preventative Medicine on the health services research as well. So it's a pleasure to welcome Evangeline to highlight some of the project and the changes that she managed to make on cancer care in the region. Evangeline.
Good evening, everyone. Thank you for the kind introduction, Mahesh, and the invitation to present today. So I've been chairing the lung MDM over the couple of years, and I lead the thoracic tumor stream within the medical oncology service. So I thought I'll talk to you a little bit about some of the work we've been doing within the multidisciplinary team. So we know that multidisciplinary meetings are collaborative gatherings of health professionals from various specialties involved in the care of cancer patients. They're also often referred to as tumor boards. They provide a platform for specialists to discuss individual cases and come up with the best course of action and management plan for our patients. So in the literature, MDMs it's been shown to increase treatment utilization rates and increase the delivery of evidence-based care. There's more guideline concordance when patients are presented through a multidisciplinary meeting. And there's also evidence that it can improve patient survival. So in this current day and age, MDMs are almost mandatory. Every new cancer patient should be discussed in a multidisciplinary meeting for us to develop their, comprehensive treatment plan. So our lung MDM, like every other MDM, is composed of different specialists, which includes the oncologists, radiologists, surgeons, palliative care specialists, pathologists, and specialist nurses. Each member brings a unique skill set and perspective to the table, and it helps us understand the patient's condition in a more holistic perspective. And the purpose of the meeting is for collaborative decision-making and for us to make comprehensive treatment plans. And the end goal is to improve patient outcomes. Yeah, so the GRICS lung MDM happens every week. It happens on a Tuesday morning between 8 to 9 a.m. We have a set agenda that gets sent up every week, and we have a specific meeting structure. So the clinician taking care of the patient presents the patient's case. We look at their radiology, pathology, and then each specialist then puts forth their treatment plan and perspective. On average, we discuss about 5 to 10 patients every meeting, and patients from all the other Gippsland satellite health services are also presented in the meeting. For example, from Sale Hospital, Dr. Nizam dials in whenever he has a patient. And so I think all of the Gippsland patients get a chance to be presented in the MDM. And we use the cool software for recording patient information and also churning out our agenda. So in terms of, I've been thinking about, yes, we've been running the MDM for many years now, and how good is the quality of our MDM and assessing if there needs to be further work done in terms of improving the quality of our MDMs. So there are 4 things we can look at in terms of quality improvement within the MDM. The first thing is documentation and data integrity. Gemma and team have been working on this extensively, I know, with their minimum data set checks. Gemma sends an email to all the concerned clinicians every week with the minimum data set checks to make sure we are filling in the minimum data that's required for example, the patient's smoking status or their performance status, all of those kind of information. Second thing is, one way of looking at quality is to benchmark our performance with other metropolitan hospitals or other clinical registries to see how we are performing compared to other hospitals in Victoria and nationwide. I'll talk to you a little bit more about that in my further slides. Thirdly is to assess patient outcomes. I guess the ultimate way of knowing if something's working is to look at if patients are benefiting or not. So we can look at things like survival or if their quality of life is improving by doing a certain process. So again, I'll elaborate on that further. And the last way of assessing if something's, if the quality of something's good is by using validated tools. There are validated tools in the literature called the MODE tool or the MODE Lite, which is an abbreviated tool, which is used to basically evaluate the performance of an MDM. And the other way this is kind of lending itself to the quality improvement of the whole thoracic tumor stream is by, it lends itself nicely by donating its data to the Gippsland lung cancer database. So the data that's collected into the lung MDM is then, we recruit those patients and use that data to go into the lung cancer database. And this helps us with formulating quality improvement projects for the whole lung cancer tumor stream as well. So just coming back to these two things, I'll elaborate on this further now. So this is a project done, myself and Lois, who's one of our medical students who rotated through our unit, looked at this year. This is actually looking into the factors that are associated with non-presentation in a multidisciplinary team meeting for lung cancer. So we present almost all our patients through the MDM, but we want to identify those who are not getting presented and what are the factors that might be, the reasons why they may not be getting presented. And she presented this as an oral presentation at the Drivers Conference in Monash University. So the objectives of this project was to evaluate the percentage of newly diagnosed lung cancer patients discussed in the MDM within a specified time frame, compare the performance of our hospital lung MDM with other metropolitan hospitals, analyze the demographics and clinical characteristics of lung cancer patients who are not getting presented in the MDM, and finally is to look at the survival difference between whether they get presented or not. So a total of 305 patients were included in this analysis, and they all had a diagnosis of lung cancer between 2019 and 21. We collected information relating to patient demographics and some clinical pathological data as well. This included things like their age, gender, postcode, histology, smoking status, and ECOG performance status. And we used logistic regression analysis to tease out factors that were associated with non-presentation and Cox proportional hazards for survival analysis. So if we look at this pie chart on the left, a total of, out of the 305 patients, 257 got presented, which is a really good number that accounts to 84.3%. And a small proportion of patients were presented at external MDTs as well, where they got initially worked up before getting referred locally. I just want to minimize this, so I'll move this away. So if we look at this funnel plot over here, this is actually taken from the Victorian Lung Cancer Registry Annual Report 2020. So if we look at this funnel plot, the average presentation number for health services that go into the Victorian lung cancer, they include about 20 different health services across the state and some outside Victoria as well. The average number lies between 70 to 80%. There are some outliers below the average and above average. But I think we are sitting quite comfortably on top of, or almost on top of the average. So I think, in comparison with other metropolitan hospitals, we are performing quite well in terms of taking at least 80% of our patients through the MDM.
Evangeline.
Yeah.
For the 15%, that includes the people that were discussed at other MDMs, so they don't get
Leave
presented.
the question to the end
It
because we don't.
includes the patients, it includes in the presented criteria.
Oh, okay.
Questions at the end because we have some webinar. Hang on.
Okay. So if we look at the factors that are associated with non-presentation, I have just included just the significant ones. So smoking and ECOG status were associated with non-presentation. What that means is patients with higher ECOG performance status were not getting presented, which is exactly what we would expect. So those really frail ECOG 4 patients who might be directly getting admitted to hospital, perhaps are not getting presented. And smoking was quite a significant factor that was associated with non-presentation. And the only mechanism I can think of is probably the ones that are currently smoking have more advanced cancers or progressing quite rapidly. And that might be a reason why, that's a significant association. And the only other thing I want to highlight, I am rushing a little bit because I've had a 5-minute one. So the distance, I want to highlight that the distance from LRH, so distance of patients' residence from LRH was not a significant factor. And that's really important to know because even the ones that are living remotely in Raymond Island are still getting presented and they're not getting flagged as non-presented. So I just wanted to highlight that. In terms of survival outcomes, we didn't find a significant difference statistically. However, numerically, there seemed to be a difference. So I wonder if, if we risk adjusted them according to stage and age performance status, maybe we might find a significant difference, but numerically, it seems quite significant. The presented patients had a survival of 33 months and the non-presented one 18 months, but we do have to stratify them according to stage because obviously the earlier stage patients are getting presented more, that's going to bias the survival. Oops. So in summary, MDTs are quite crucial and nowadays they are considered best practice that all our patients go through an MDM. Latrobe has comparable MDM presentation rates compared to other metropolitan hospitals. And this study highlights that there's a numerical survival difference between the ones who get presented and those who don't. Now, just a couple of slides on how the lung MDM data lends itself to the lung cancer database. Now, as I mentioned before, the data from this MDM is used to recruit patients for the database. We collect, apart from the MDM data items, we do collect other information related to their treatment, and we do actually go in quite a bit of detail in terms of how they were diagnosed, and timelines according to OCP as well, referral to first referral to specialist appointments to treatment times, those kind of things. At the moment, we have up to 700 patients in this registry with complete data, and Cassie has been working extensively, putting in a lot of time to support this, and Jody as well previously. So thank you for that. And this has actually helped us to generate research, which is then helping us to focus on quality improvement initiatives. This year, we've had a driver's oral presentation, 3 abstracts, and our oncology advanced trainees are also utilizing this data for their projects as well. So in terms of future directions in 2024, we do want to make the database more complete by capturing all our patients and including the ones that we're missing in the MDM by recruiting patients from CHARM and other resources as well, so that we have a complete list of all the lung cancer patients in the database. And we do want to make focus on passive data entry and data linkage, so we can reduce the time and resources that's spent on actual data collection. Thank you. I think we're finished.
30 seconds.
Okay.
Thank you very much, Evangeline, for that great presentation on how the progress is made on making sure that our care is as good as what's happening in the medical areas and developing this program of research that will help to drive change and outcomes for our patients. So I think we will leave all the questions to the end because of the interest of time, but moving on, next is a presentation by Dr. Taha Al-Mufti. He's going to be talking about the rapid access clinic. Taha Al-Mufti, he was our advanced trainee for the last 6 months. He trained in Iraq and has been in Australia training in medical oncology at multiple sites, and he's currently at Monash and he's joining in virtually to present his data about the rapid access clinic and how that's helping our patient journey and our patient pathway.
Hello. Yes, thank you everyone, and thank you, Mahesh, for the introduction and giving me this opportunity. Can you hear me and see the slides clearly?
Yeah, we can hear you.
Yeah.
We can't see you.
We can't see you.
Yes.
But you can't see me, right?
No.
No.
But you can see the slides.
Yes.
Yeah, that's right.
This is the point, which is for you. Good. I don't want to scare you. All right. Yes, so it was one of the best 6 months that I spent in the last 20 years of my clinical experience and that I had in multiple different countries overseas and Australia. So I'll talk about the rapid diagnostic clinic, a new care model for suspected cancer patients in regional areas. So why did we start the diagnostic clinic? I have been privileged and tasked with the triaging all incoming referrals as an advanced oncology registrar, advanced trainee. A notable challenge arose with referrals that indicated a suspected radiological diagnosis of cancer but lacked the confirmatory tissue diagnosis. And to look at the patient's geographical distribution, I found it really challenging looking at the Gippsland area, the referrals coming from East Gippsland, Wellington, Global, Latrobe, and South Gippsland. So this is really posed a challenge, and the travel burden for assessments, at least 2 to 3 hours drive to come to the clinics for an assessment. So in order to solve any problem, the first step is to measure it. So I started collecting data and getting a weekly data feedback on how many patients we are receiving per week, what are the patients doing, when biopsy required, when the biopsy happening, and when we are getting the results. So basically, I started to monitor patients' journey through the process of workup investigations. So the data collection, and this slides really, I want to emphasize on the importance of data collections. The Sumerians, are people who lived in Mesopotamia, which is in Iraq now. They invented writing, and this is the invention of writing and the dawn of record keeping. In his book, Sapiens, Yuval Noah Harari describes the invention of writing by Sumerians as a means to overcome the human brain's limited capacity for retaining data. It's around 3,500 BC. And this is the first cuneiform template. It basically was a receipt that exhibit here the sale transaction of an ox. This evolved into a writing. So basically data collection is important in everything that we do in our life, and it can evolve in very useful things. So a small change, big difference. Like refining the biopsy referral process. And initial expectation when I started at Latrobe Regional Hospital, when I request a biopsy, I was expecting that I would get it to be done within 1 to 2 weeks. However, the process delays because the fax sent to Central IMED to Melbourne, then it will get triaged again, then sent back to the local Latrobe Regional Hospital. And then again, a triage again, and a medication list was necessary for discussion with interventional radiologist, and sometimes leading to deferral if deemed unsuitable. And if deferred, we will not get notified, and we don't know that the biopsy is not happening. This led to the streamlined solution that we created. This is a simple change I'm mentioning. A direct biopsy fax number was established, simple like that, that we send the request from the GRICS clinic directly to Latrobe Regional Hospital. And this really resulted in the cut down several weeks in delays just by performing the biopsy. The final step also, we created a biopsy meeting implementation. Weekly meetings at 2 p.m. on Fridays with the lead interventional radiologist were introduced, reducing the waiting period by 2 to 3 weeks. So 3 weeks has gone just by this small change process. So March, April, and May, we finished work diagnosis for 50 patients as a sample to start with. So the mean age was 73 years old. Geographical distribution, 17 from Latrobe, Wellington 14, East Gippsland we got 10 patients, Bobo 6, and South Gippsland 3 patients. Mainly males, 34 and 16 females. The duration of symptoms, and really it was 15 weeks. So 15 weeks before presenting to their GP. Then the referral time to first consultation in days, 11 days. We managed to see them within 11 days from patient's GP letter to the GRICS. 7 patients failed to attend, multiple reasons. Most of common things that GP send the same letter, multiple copies to different sites, and patients go to a different site or prefer to not present to us. So in terms of biopsy recommended, we got 33 patients required a biopsy. Surgical 8 patients, ultrasound guided 14, CT guided 16. So it's 20 done by interventional radiologist at LRH. Bronchoscopy 2 and 2 EBUS needed to transfer to Melbourne, and 3 patients did not proceed. In terms of MDT discussions, the total 21 patients discussed. Here, I just want to highlight the privilege of the MDT meetings at LRH. We have lung, surgical, lymphoma, advanced. I run these cases through the MDT before confirming a diagnosis or tissue diagnosis to get an opinion from the different specialties. What's the best biopsy? What's the next state of management? So this is really was a very good service available at LRH. The time to diagnosis, we managed to diagnose them within 13 days. 43 patients diagnosed between March and May, 12 lung cancer, 7 lymphomas, 4 genital urinary, mainly prostate, 2 breast cancer, upper GI, melanoma, and 1 colon cancer. I'd like to mention here 8 non-malignant or benign diagnoses, sarcoidosis, vasculitis. It was interesting medical cases, which also helped the BBT, who's doing the training and helping to run the clinic and getting the history from patients to improve the skill of becoming a better diagnostic physician. In terms of staging, early stage 6 and
Mr. Taha.
Taha, we've lost you.
Please.
That'd be Taha.
He seems to have lost the connection. Maybe it's the Optus link being playing up again.
Pause his time.
Okay, hello, we lost you, huh? Can't hear you at all. We are lost you at that 50. You know, testing my memory.
That's the last.
It's gone. Last, can you put up your, where are you up to? Can you just reconnect us? No, we can't hear you now. Like I can. Nope.
I think we got most of the, I think that's most of the slides, isn't it? I think this, yeah. So thank you very much, Taha. That's highlighting how the process have been developed, and while he was there, and now it's still continuing for earlier diagnosis of patient and making sure that we improve the patient flow and allow patients to much more smoothly navigate the healthcare system as far as biopsy and diagnosis is concerned. It is very important because we're getting a lot of referrals from the GPs, and so far this clinic has seen nearly 100 patients this year. So it's a really a valuable addition to our local service. So I think thank you very much for that talk. I think we will, because in the interest of time, we should move on, and we will have questions at the end. So next is Dr. Sachin Joshi, who's been working in the region, developing services and optimizing care for a long period of time, and he's been leading a project on multidisciplinary management of advanced solid cancers, try and improve patient management as well as recruitment into clinical trials locally as well as at other sites as well. So it's been a very important piece of work, and he will be presenting on the findings. I know that's been presented at other meetings, including drivers and the COSA meeting nationally as well. So Sachin, over to you.
Thank you. So you are managing the IT. And so good afternoon, everyone. Thanks again for giving me an opportunity to be here and present the work which we have done. So when I'm presenting the work, it's individually, it's not one person's work, to be honest. It is the people who have behind this work to actually facilitate this multidisciplinary meeting happen. Now, Evangeline has already informed about what the MDM meetings are and what the important role in the cancer management is. So can you move to the next slide? Yeah, so again, just to emphasize this picture is, there are multiple specialties and subspecialties join hands together to derive the main objective of the multidisciplinary meeting is to actually, can you go to the next slide, please? Is to actually develop the comprehensive, collaborative, personalized care for the patients affected with advanced cancer and provide them an evidence-based optimal care for their management. The people who are involved in this one is not limited, but at least they are medical oncologists, the surgical oncologists, the radiation oncologists, the palliative care physician, palliative care nurses, the radiology, pathology, the cancer research team, both locally as well as to the metro, people, nurse practitioners, advanced training, and allied health professionals. So this is the ideal team which we are working towards. There are some of them are missing at the moment. That includes the allied health professionals. Apart from the palliative care team at the moment, radiation oncologist has been joining on and off, but there are the much more regular ones. Pathologists, we started initially with, but then we dropped out, so we're still working with the pathology team. So there is a quality improvement opportunity available in the near future, but that's the optimal team I'm looking forward to derive the objective just defining my first point. Steve, you could go to the next one. So So what is an advanced cancer? So this is a cancer where the curative surgery on primary is not feasible, or even if it is feasible, they are unlikely to change the outcome of the patient. So either the patient may present here as a de novo metastatic disease or de novo advanced disease, or may have had previously curative intent treatment, either that could include the surgery, chemo, radiation, and or often most likely a combination of these treatment modalities. However, then they have unfortunately relapsed after initial attempt to cure from there. In Gippsland, prior to the October 2021, we had initially the breast, skin, GI multidisciplinary care meeting. We have ad hoc urology multidisciplinary care meeting, and India is already presented as. But there is absence of the dedicated multidisciplinary care meeting, only focusing on this advanced cancers, and that's one of the gaps which we try to minimize through this initiative. Move on to the next one, please. So we consider, like, why do we need this MDT? Like, what is the purpose of this establishing MDM? One of the reasons is, we already, this is an example. In year 2022, we had 520 new patient referrals to the oncology status. Out of that, 233 of them has a documented advanced cancer at the time of the referral. However, that does not include the people who might have relapsed in the year who has previously received the surgical treatment. So I estimate there are more than 233 plus patients who are been diagnosed with the advanced disease in that year. So if you look at the percentage wise, we're always looking at around 30% plus patients who are referred to the Victorian Cancer Care Center has the advanced disease at the time of the diagnosis, as well at the time of the referral. The likelihood of them to be presented in the multidisciplinary care meeting is unlikely to be as prevalent as it could be in the curative setting. There are a lot of Victorian tumor summits or data which has been presented, which supports my statement, which I said, which are one of the examples I will show you in my next slide. And we already know that metro versus regional patients are likely to have a much more delayed presentation as compared to metro. That could be one of the factors of having the low 5-year survival. And at the same time, I suspect the COVID may have had a negative impact in a cancer as a whole, and particularly the advanced cancer incidence might increase because of the patient's reluctance to proceed ahead with the screening program and opportunity to diagnose earlier. Not just screening program, even looking up, going up and getting this help from the primary health might have impacted on their opportunity to earlier diagnose. So one of the data sets which are to support this one is, if you look at the patients presented at the MTM in a non-metastatic metastasis at the diagnosis versus metastatic at the diagnosis for upper GI through the upper GI cancer registry, there are 63% of them would have been presented if we had non-metastatic disease, but only 38% of them would have been presented if they have been presented as a metastatic setting at the time of the diagnosis. So almost 50% difference between the two of them. And we can move on to the next one. So the question arises, why do we need another meeting? Then we have already existing infrastructure, and every MDM is a cost to the organization. So you have to get the time for the medical oncologists to sit down there. The governance structure, the facilities, dragging the pathologists, dragging the radiologists in the meeting, what is actually requirement and what the evidence that there is a requirement. So first is, there's a lot of difference between the advanced cancer and early cancer. They have their unique needs. The treatment regimes are more complex. The adjuvant treatment are usually options number 1 or 2. For example, colorectal cancer patient, metastatic at the earlier setting, and adjuvant treatment, we have 5-fluorouracil plus or minus oxaliplatin. Breast cancer, anthracycline, taxane. So these are, if you look at the complexities of the treatment regimes required, and even the importance of the sequencing of the treatment pathway required is a very unique and is a very tailor-made requirement in a patient with advanced disease as compared to the earlier cancer. The clinical trials and the research opportunities can be provided through this multidisciplinary care meeting. And the complex investigations like precision oncology, has been linked through this MDM. The other thing which I haven't mentioned in this MDT, what Taha has recently presented for about the early access clinic, this MDM actually been backbone or been supportive of the complexities of the investigations required or interpretation of the investigation happened through that project or through that clinic. This meeting has actually supported multiple needs for the cancer management in the Gippsland. The supportive care needs, including the palliative care need, cancer care nurses, has been part of it. And one of the highlighting part of this one is actually improved opportunities for the education and reducing the variances in practice. There are the two examples I can talk about just in my top of head. There has been one question which has been repeatedly asked about, how frequently we should, can we use the temozolomide, that is one of the drugs in the management of the brain cancer beyond the 6 months. So once the question has been repeated 3 times in the MDM, I have tends to get the metro specialist in that tumor stream to actually come up in our MDM and present that question and address that question so that we have, we have one answer to that one question and we need myself analysis afterwards. There has been presentation by Dr. Michael Hoffman for the referring to the metro for the lutetia PSMA for the prostate cancer. So the educational needs as well as the opportunities to have some common understanding in managing the complex cancer patient has been one of the hallmark of this MDM. So the number of the types of the tumor streams presented has been quite significant. There are more than 10 or 15 types of the cancer types has been presented. And one of the comment made by my colleague was this is a fantastic MDM which allows us to present everything on the which falls on the sky, which does not fall in other MDMs to be actually come up on this one and have discussion, and it has significantly reduced our corridor discussions, which sometimes can be taken in the context of not having the patient's complete picture or not being able to access to the radiology and pathology in that corridor discussion. So that's the other part of this MDG. So how did you do? So just in terms of the number wise, so first presentation to the Gippsland MDM has been around 32%. So the patients who are presented to the advanced disease entity, 32% of them has not been presented to any other MDMs, at least in the Gippsland. So they might have been presented to the other MDMs, which I do not have the data about. There are around 13% of the patients has been multiply presented in the MDTs. And around 55% of the patients we don't have the data about. The clinical trials input has been discussed around 21% of the patients, where there has been very strikingly clinical trials which might be considered for the patient to be enrolled. Either it could be locally or it could be in the state, particularly the Alfred trial fellows who joins in is supporting the trial needs for our cancer patients. And then they have, according to the people who are working in the clinical trials, have the better understanding of the lot of other trials opportunities are available externally. 5 minutes warning is noted. So those who are dedicatedly working in clinical trials may have much more better awareness of what other trials are available, not only including on their center, but including the other centers as well. The palliative care needs has been improved with the 72% of the patients has been discussed about the need for the palliative care services. Now we can go to the next one. As I previously mentioned, the use of the expert opinion to improve the quality of the care has been utilized in this MDM. So before I move to the next slide, there's one more graph which is not there, which is very another important point of this through this MDM was that around 12 patients out of 100 patients who've been presented, the recommendations has been no further systemic therapy. So that MDM is actually not just only suggested to continue the patient's treatment options, but even to stop at the fertile treatment management as well. When the clinicians together felt that any further systemic chemotherapy is unlikely to benefit the patient's outcome, and that's where the recommendation has been made. So it would be interesting to see the role of the 30-day mortality role, the impact of this MDM after looking at what is before 2021 as compared to 2023. This again just highlighting the importance of the work togetherness and the opportunity for us to mentor our medical students to to drive the protocol, write the protocol, analyze the data, and write up the poster. So Brittany Sooty is one of my medical students who has done an excellent job. She presented in the oral presentation in the driver conference and has been presented in the COSA conference as well. Yeah. Thank you.
Thank you very much, Sachin, and thank you for all the three presenters who really did an excellent job on highlighting the importance of the projects and the results and what they led for real direct patient care improvements and how it's driving really the quality assurance and quality improvement project that we all want to see to help patients in the region, which is much needed. And we have a few minutes for questions if there's either on the chat or here locally. And certainly, I was really impressed with the analysis of the data that Evangeline and that really is really quite useful for us to sort of dig down and that's really almost a publication on its own, sort of really sort of looking at that sort of, because I don't think there's any regional data on that. Yeah, Juan?
Yeah, Evangeline, with that project that was there, the other barriers, because there wasn't a lot, I guess, found. Did you look at like SES, or was that feasible? Education levels or something like that as a barrier, or can that be found?
So looking at health literacy.
Yeah, I'm just wondering why are they coming? Because to present smoking was a factor, it's a hard.
It's a bit hard to actually collect health literacy and socioeconomic status. The data for this was obtained from the lung cancer database that we already have, and we don't collect variables.
Yeah,
You
that's
have
not.
to get the Bureau data and compare the SES, because I mean we know that certainly in Latrobe the SES is very low. So I think you could do that with.
It might vary based on postcode, but then postcode itself was not a factor.
Yeah, I know, I saw that. So.
So I think that's really interesting because I think that was very, very encouraging to sort of see that we have sort of accessible from a point of view.
Yeah.
And
There is within Gippsland. Yeah.
I just had another question. It was for Sachin, but maybe you might be able to help. In the presentation, there was a comment made about 500 patients being referred, or the cancer services received 500 patients. Well, that was what he said last year, and I was just curious to ask where that data is from.
It'd be through GE.
Data.
I think it seems low.
Yeah, I thought.
Number of referrals to last year, 500 something.
Through the HIVI's data set.
Okay.
So he was collecting the data for the our referrals. Yeah.
So that's not accurate anyway, because a lot of them are mentioned, aren't they?
So yeah, so
500 is kind of
all these things are missing data. I mean, it's really no comprehensive list. You can,
And so the data for the advanced disease MDM, is that through cool?
That's
that way you got it.
yes, yeah.
Okay.
Yeah, I think so all integrated, so we can look at the data in a robust way. So it's all in cool and you can get reports and things like that. So that's the value of what's happening, and then really sort of how we can build on that to try and have more robust, more sort of live data that's coming through.
I have one question first too, actually, with the cancer council liaison nurses. What exactly is their role?
So their role is kind of a dual role. So they had, do you remember that access program from last year? So they had an access project, which they increased the amount of nursing EFT available on the 13, 11, 20 phone line. But then based on the increase in referrals to that supportive care service. So in Gippsland and in Barwon, they saw the need for actual feet on ground nurses. So the role of that liaison nurse is kind of to support the chemo day units, as well as be like a face if someone needs, additional supportive care. They're kind of a face for Cancer Council that person can be referred to.
So they are on ground here.
Yeah.
Are they part of
So-
service too? No.
No. So they're employed by Cancer Council Victoria. And so they're on the 13, 11, 20 phone line 3 days a week, and then 2 days a week, basically just traveling around the region.
So I was actually, planning to apply for lung cancer for a lung cancer nurse for the service, and I wondered if that could be facilitated through that.
Different. I mean, this is that CCV funded different role. Yeah, so this will be completely their funding.
More money.
Yeah.
Their money getting so demonstration, and it's only a pilot for a bit. So this year, and then they're going to see anything on the chat? No. And is it any other questions or anything? So I think we sort of highlighted important things that happened this year, and that we need to sort of build for next year on the sort of the processes that we developed this year to try and really have a good projects that we can do the involvement of ourselves as well as the teams, the registrars and the medical students that really sort of drive change for our patients. So all this is possible because from a GRICS point of view, the team, I'm just talk a lot at and it's everyone else who does everything else, and then the oncologist and on the ground and all the allied health professionals and everyone in the day and do all the sort of the hard work. So thank you very much for everyone, but it's great to see that we're really sort of moving the bar on the quality of care that we provide as well as the quality of the service, and we just need to sort of try and build on that to try and drive change. And as I said, to try and get rid of these differences between regional and metro outcomes. So thank you for attending and thank you for joining us. And